Hey guys, this is Ronnie. Our presentation is going to be on myasthenia gravis, or more commonly known as MG. This is a lot of information, so feel free to pause and take notes. Okay guys, so we'll start off with the pathophysiology of MG. MG is an autoimmune disease affecting the neuromuscular junction of muscle cells. Antibodies are created that target the muscle receptor sites, also known as acetylcholine receptors, that allows for nerve signals to create stimulation for muscle contraction. With these receptor sites blocked or destroyed by the autoantibodies, there are fewer nerve signals to allow for muscle contraction, which can result in generalized weakness of voluntary skeletal muscles. These anti-acetylcholine autoantibodies can be detected in a blood serum of 90% of patients with MG. And the thymus also appears to be involved in the production of these acetylcholine receptor autoantibodies. It is usually inactivated after puberty, but in adults with MG, it seems to be a source of acetylcholine receptor autoantibodies. Removal of the thymus can significantly improve symptoms of MG in most patients, which will be further discussed by Krista. The other 10% of patients that have MG could also be caused by an autoimmune disorder of the protein tyrosine kinase. This protein is also involved in stimulating muscle contraction. The onset of this disease is around the age of 28 in women and the age of 42 for men. Women are more susceptible to having this disease than men. Okay, so moving on to gerontologic considerations. Older patients may already experience reduced mobility and musculoskeletal impairments from aging. Around the age of 70, approximately 30% of their motor neurons are lost. Older patients also have less flexible tendons and ligaments, so their movement becomes more stiff. With the onset of MG, it can further reduce their musculoskeletal functions. It is important to assess their gait and their ability to ambulate as well. The biggest concern that we have is a risk of fall. An elder patient has less bone density, so a ground level fall can result in significant injuries such as bone fractures.
Hey guys, it's Krista. So I'm just going to go over some the main cause of MG before I move into signs and symptoms. So although it's not completely understood, MG is an autoimmune disorder whereby the abnormal thymus gland activity leads to antibodies that actually damage the neuromuscular junction. So then the acetylcholine is no longer as effective as it once was, and muscles don't receive their stimulus. So then that's why we see these signs and symptoms. Okay, so with signs and symptoms, the primary feature of MG is fluctuating weakness of skeletal muscles. The condition usually affects multiple muscle groups such as your face, your lips, throat, tongue, neck. So as you can see in the images here, there's a significant drooping of the eyelid, which is referred to as ptosis. And diplopia is another manifestation of MG, and this term refers to double vision, which is the simultaneous perception of a single object. So the muscles associated with MG are generally strongest in the morning, and they become exhausted with continued activity. At onset, only the ocular muscles are involved for about 50% of patients. So this results in the bilateral ptosis that we were just talking about and constant or transient diplopia. The disease does not progress beyond the ocular muscles in about 20% of patients. When facial muscles are affected, facial mobility and expression can be impaired. So this is why you'll see sometimes patients will have a blank or expressionless face. Patients may also have the difficulty with chewing and swallowing food, since, like I said, the body parts that are most affected are the face and the lips and throat and tongue and that kind of thing. And so that also can affect their speech. And the voice often fades after a long conversation. The muscles of the trunk and limbs are less often affected in this disease. And I want to make sure to point out that no sensory loss occurs. Your reflexes are normal, and muscle atrophy is more of a rare thing.
Myasthenia gravis, or MG, can be difficult to diagnose because weakness of skeletal muscles is also a common symptom of many other disorders. However, diagnostic studies that can be done to confirm a diagnosis of MG include history and physical examination, single fiber electromyography or EMG, tensilon test, acetylcholine receptor antibodies, chest X-ray, and chest CT scan may also be done to evaluate the thymus. Now, for the history and physical examination, the patient may be asked to provide a family history of MG, testing the patient's reflexes, muscle strength and tone, posture, coordination, balance, etc. For the single fiber EMG test, it is used to record the electrical activity of muscles. This test can provide information about the connection between the muscle and nerve. A brief description or what a patient might expect during the EMG test. A ground electrode will be positioned under the arm or leg of the patient. A needle or needles are inserted through the skin into the muscle. The electrical activity is detected by this needle. The patient will be asked to perform muscle contractions during the procedure, and you guys can see a picture on this slide of this type of testing. Also, the patient may show a decreased response to repeated stimulation of the hand, for example, and which is an indication of muscle fatigue. The tensilon test consists of an IV injection of hydrofonium chloride. This drug is a short-acting anticholinesterase that inhibits the breakdown of acetylcholine and improves muscle tone. If the patient's strength improves after administration of these drugs, it is an indication of MG. It is also important to have atropine, which is a cholinergic antagonist, and it should be administered to counteract the effects of tensilon. Lastly, a positive acetylcholine receptor antibodies test may be indicative of MG. These antibodies are present in 85 to 95% of MG cases.
So for treatment of MG, there are a number of options that people can use for that, inclusive of medications, surgery, and plasmapheresis. So for medications, the general medication that's used is a muscle strengthener and steroids, and anticholinesterases such as protosigmine or methanone, which is a muscle strengthener, can be given on a daily basis. It's usually recommended to give 30 minutes prior to meals, and then you would monitor for any allergic or adverse reactions such as swelling face, tingling in mouth, throat, or slow and uneven heartbeats, as well as muscle twitching. Methanone is the most successful drug in the long-term treatment of MG. For corticosteroids, the most common one is prednisone that you would use, and that would help with any inflammation. And then immunosuppressive agents such as cyclosporine, mycophenolate, azathioprine, and those would also assist with the treatment as well. Surgery, which is a thymectomy, and that's the removal of the thymus. That'll be talked about a little bit on the next slide. Plasmapheresis is a blood transfusion to filter the blood and remove any anti-acetylcholine receptor antibodies. It can be given during an exacerbation of the disease to remove the antibodies during this time. And we can also use IV immunoglobulin G to assist with treatment of MG. This slide here shows an overview of the thymectomy. So it is an operation to remove the thymus. Generally, if a thymoma is present in the thymus, which is in usually 10% of patients, then the thymectomy is mandatory, and that's just to prevent further spread of MG. As mentioned earlier, the thymus is somehow involved in the production of the antibodies that are destroying the receptor sites, so removing the thymus would help to improve the weakness that is caused by MG. And there they show the video thoracoscope that's removing the thymus gland in the picture.
Okay, moving on to complications. Complications include aspiration and pneumonia. These complications can fall under one of two crises that people with myasthenia gravis may encounter: myasthenia crises and cholerogenic crisis. Myasthenia crisis is triggered by respiratory infection, surgery, or emotional distress. It also can be triggered by pregnancy or exposure to certain drugs. To treat, the patient is given a dose of tensilin. If someone is in a myasthenia crisis, tensilin would improve their signs and symptoms. Myasthenia crisis would manifest as a sudden exacerbation of muscle weakness, respiratory failure, and aspiration. Cholerogenic crisis is an overdose of cholinergic medication, severe muscle weakness, vertigo, and respiratory distress. When given a dose of tensilin, if someone is in a cholerogenic crisis, it would make their signs and symptoms worse. This is usually okay because it is given IV, and the increase in symptoms would only last a few minutes. As mentioned earlier, we can go ahead and give atropine to counteract the effects.
For the nursing diagnosis, we have ineffective airway clearance related to intercostal muscle weakness and impaired cough and gag reflex, impaired verbal communication related to weakness of the larynx, lips, mouth, pharynx, and jaw, activity intolerance related to muscle weakness, fatigue related to paresthesia, aching muscles, weakness, and disturbed body image related to inability to maintain usual lifestyle and role responsibilities.
With the interventions in the nursing management for MG, these would correlate to the nursing diagnosis that were previously mentioned. So a number of them would include making sure the airway is clear, so you would maintain a clear airway. Definitely assess for fluid to avoid aspiration, check their respiratory rate, depth, and O2 saturations, as well as their PFTs. Check their muscle strength, especially if in a crisis, to include any cough and gag reflex. You would assist the patient with turning, coughing, deep breathe exercises, and assess the ability to chew and swallow. You would also make sure that they are, of course, staying hydrated and give methanol 30 minutes prior to meals as well. And semi-solids may actually be easier for a patient to swallow than solids and liquids. Additionally, you would assist with monitoring weight and just educate your patients about support groups and counseling, and just make sure they are getting any necessary nutrients as well. Try and helping them to maintain as best of a lifestyle as possible.
All right, so just as a little overview here, we can take a look at what we've talked about. So patho, we said it was an autoimmune disease. Gerontologic considerations, reduced mobility, decreased flexibility in tendons and ligaments. Signs and symptoms, we talked about muscle weakness, the dysphagia that can result, ptosis, and diplopia. Labs and diagnostics to do, single fiber EMG, the tensilin test, which we talked about, acetylcholine receptor antibodies test, chest x-ray, chest CT scan. Treatment, the drugs listed. Complications, aspiration, pneumonia, myasthenia crisis, and cholinergic crisis. Okay, so last thing here, guys, is some nursing management for a few nursing diagnoses that we came up with. Ineffective airway clearance, impaired verbal communication, and impaired swallowing. Feel free to definitely pause this slide so that you can see the different things that we would do in these given situations. Also, for reference, we listed the chapter MG is located in, along with the page number, so definitely check that out in addition to this PowerPoint. Thank you for listening and watching, and happy studying!